In today's, you are consenting to being recorded, and if you do not wish to be recorded, you can leave the session at any time. We have been in the Zoom realm for a while, but if you have any questions about Zoom functionality, like renaming your profile, changing your background, or raising your hand, you can send me a message. I'm happy to help figure those types of things out. Where this is an echo session, we often have discussion elements that include talking about experiences that we have had or other people's experiences that we've learned from. So if you're sharing information about another person, just be sure to avoid using any identifying information that could look like their first, middle, or last name, initials. Don't identify any family members, friends, contact information. If you have a question about something you want to share and you're not sure whether or not a piece of information is identifying, again, you can reach out to me and I will help walk through some of that to make sure we're good to share what you'd like to discuss. Where this is an echo session, this really works best if everybody participates, especially when we get to our case scenario discussion. So I'd appreciate it when we get to that point if you'd be willing to unmute and or turn on your camera if you're able to and participate in that discussion. Our case scenario discussions are one of the best ways we can use to solidify skills that we learn in these presentations. So if you have a case scenario you'd like to discuss, that you would like input from your peers on, you're welcome to reach out to me and we'll put that together for our next echo session. I will drop my email in the chat here, and you're welcome to reach out to me with any questions about case scenarios if you have something you'd like to submit. We'll start out with our didactic presentation. We are super fortunate to have Brad Saunders here today, and then we will wrap up with the case scenario and some feedback and discussion as a group. Again, if you have a case scenario, so something that you're dealing with right now, or maybe something from the recent past that you'd like some input on from your peers and our presenters, you can reach out to me at rachel.byers@usu.edu, which I have also dropped in the chat. We do offer free CEUs from the Utah Social Work Association for your attendance if you would like those. We also have certificates of attendance available. If you would like either of those, you will need to complete our survey, which the link is available in the chat. We'll add that a few more times just to make sure you have access to that. And you'll be able to fill that out and let us know what kind of certificate you'd like. If you'd like to have access to previous session content and slides from something like today's presentation, you can join our iEcho platform. If you're here at today's session, you probably already are part of that iEcho platform. But if you are not and you would like to join, again, you can reach out to me and I will make sure we get you registered. If you'd like to learn some more about future opportunities in this echo, as well as other echo training series we have going on at the IDRPP, you can check out our social media. We have Facebook and Instagram pages. Those are our handles, or you can scan this QR code and that will take you to our social media as well. Our next session currently planned is for Monday, December 16th. That session will focus on facilitating and supporting skill building for individuals with mental health concerns who also have intellectual and developmental disabilities. If anything does change about that session, we will be sure to communicate via email and on the iEcho platform. So finally, I get the pleasure of introducing our presenter today, who is Brad Saunders, a licensed clinical social worker who has his Master's of Social Work degree. He has a lot of experience, both educationally and applied. He received his undergrad degree at Brigham Young University and then completed his MSW at Eastern Washington University. He spent his career working in both the mental health and DSPD systems in the state of Utah. In mental health, he started his career as a residential direct care staff for Wasatch Behavioral Health, and then later as a caseworker. Following grad school, Brad moved to the Utah State Hospital, where he started as clinical therapist. then as administrative director, and most recently as the supervising administrative director for pediatrics. Brad coordinates with the local mental health authorities and various inpatient hospitals across the state to coordinate admissions to the Utah State Hospital. In addition to his full-time job, Brad has worked part-time over his career as a contract therapist with Chrysalis, and most recently as their therapy director. Brad currently supervises a team of therapists providing clinical services for their DSPD clients in St. George, Cedar City, Nephi, Price, and Provo. Brad holds monthly clinical consult meetings with these therapists to problem solve and strategize how to best meet the clinical needs of their client caseloads. Brad, feel free to add anything to your introduction that I might have missed, and I will go ahead and turn that time over to you.
Well, thank you for that introduction. Yes, just maybe one other thing to add there. I've spent 30 years in the last 30 years in mental health, and I'll actually be retiring from the state of Utah this month. So at the end of December, I'll be leaving my position here at the state hospital, and a bittersweet time in my life to say goodbye to all of my friends here and all of my colleagues across the state that I've collaborated with over the years. I will still continue to do some work with Chrysalis as their clinical, as their therapy director, and so my plan is to continue there. But as I've worked with kind of in both of these systems over the years, I've recognized the challenges that the IDD population has accessing mental health services, and I'm hopeful that today I can share some tips, some suggestions on how support coordinators, specifically case managers, can kind of navigate through those two systems to help, first of all, access services. Well, first of all, assess if their clients need mental health treatment, and if so, how to best access that and to stay connected with those teams so that they receive the best care that they can possibly receive. So that's my introduction. I've got a presentation. We've had a few technical glitches, so bear with me. Hopefully everything will work well with this presentation. So, share my screen. Can everyone see that okay?
Looks great.
Thank you. All right, so how to advocate for individuals in inpatient settings. I'm going to go ahead and give kind of more a two-part presentation today, as I think before you jump just to inpatient settings, there's a lot that we can do through therapy, medication management on the front end, through behavior plans, to avoid those inpatient settings. So I thought it might be important if we first of all talk about just mental health treatment, how to gain access to mental health treatment. So how can support coordinators collaborate with mental health providers? I think first of all, I need to know who they are, and that communication and collaboration is so critical. I would invite you to kind of think about your caseloads right now, who you have that you support, and maybe ask yourself the question, if they're in therapy, do you know who the therapist is? Do you have their contact information? Are you able to communicate them at least, during team meetings? Are they part of that? If not, can you at least get a report from therapy on how things are going? So that communication, that collaboration with whoever is providing mental health services is very key, and you can play a very important role there. So here's just some things to do to help with that communication and collaboration. Just gather information. If if I'm a therapist working with somebody on your caseload, I would always welcome information. As you are possibly trying to get somebody to gain access to mental health treatment, whatever you can do to gather information about specific mental health concerns and provide those to a potential provider, that will be very important. Be proactive in your communication. A lot of times the therapist won't reach out to you. And so I would invite you to reach out to the therapist. Make sure that you're building that relationship early, so that you can collaborate together. And then document as you see concerns, as you're communicating possibly with that therapist. Document what you're hearing, what you're seeing, what you observe, what the family, other people in their employment might be observing, so you can get that information to the therapist. And then follow up. If you've started a relationship with that therapist, make sure that you are just periodically reaching out to see how things are going and how you can be supportive. Like sometimes just the therapist might be left out, especially when, say, your individual might be receiving services at home or with a provider, and maybe there's a community-based therapist or somebody at the local mental health authority that's seeing your client. I would invite you to get that ROI in place so that there can be communication and you can stay attuned to what's going on in their treatment. So what should support coordinators know about mental health treatment? First of all, what can be complicating is just knowing the difference between developmental disorders and how this differs from mental illness. I'm sure most of you have found out during your career that this is not an easy question, that there's comorbidities that occur, and but if we start with a basic understanding, it might help lead us to know when a mental health condition exists and when to seek treatment. So a question that often comes up with our population, with the IDD population, is autism a mental health condition? And it's in the DSM, correct? It's there. You can find it there. But overall, how is autism viewed? So the answer to this question is no. Autism, in its just a standalone diagnosis of autism, is a developmental disability, not a mental illness. And as I mentioned, though it's listed in the DSM, it is classified as a neurodevelopmental disorder, not as a mental health condition. So if you're seeking therapy, if you're seeking mental health treatment, just a diagnosis of autism won't open that door. So what else needs to happen? Let's maybe talk about a little bit more about the differences between developmental disability and mental illness. Um, um, so according to the Centers for Disease and Control, the CDC, developmental disabilities are a group of conditions due to an impairment in physical learning, language, or behavior areas. These conditions begin during the developmental period, may impact day-to-day functioning, and usually last throughout a person's lifetime. Any mental illness, according to the NIMH, is a mental behavior or emotional disorder. Mental illness can vary in impact, ranging from no impairment to mild, moderate, even severe impairment. So kind of start to see those differences. Something that here's this next slide kind of shows a table. On one side, developmental conditions. They're present at birth or before the age of 18. Symptoms and traits are present day in and day out. They usually don't, there's not episodes of developmental conditions. It's not episodic. It's more a flat line. There can be change, gradual change over time with training, with behavioral interventions, but those symptoms and traits are persistent. They may cause physical, cognitive, or behavioral challenges. Core traits cannot be cured or effectively treated with medication. If you think about it, there's not a pill that can be taken for autism. Now, that being said, there's plenty of medications that are tried to manage symptoms, moods, behaviors. When some of those behaviors are extreme, medications are used, but to cure autism, there's not a pill for that. And they're typically diagnosed by a psychologist or developmental pediatrician. On the other side, mental illness may arise at any point in one's life. It's not tied to just birth, early development. So depending on what's going on in somebody's environment, they can just arise. Symptoms may be temporary or cyclical. Causes disturbance in thinking and perception, may cause hallucinations and delusions, may be effectively treated with medication, diagnosed by a psychiatrist or other mental health professional. So what is an IDD-MI dual diagnosis? So when both of those things are true, when somebody has a developmental disorder and is suffering from a mental illness. So an IDD-MI dual diagnosis refers to individuals with an intellectual developmental disability who concurrently experience a mental health condition. While the exact prevalence is unknown, most professionals accept that roughly 35% of people with intellectual disabilities also experience mental health challenges. So if we look at, our IDD population and just say, oh, well, it's all developmental, they don't need mental health treatment, we are missing a huge percentage of people that can benefit from mental health treatment. If you look at your caseloads, if you think, okay, our roughly 35%, maybe up to 40%, 50%, are they receiving any kind of mental health treatment? If the answer is no, then perhaps we're missing some individuals on our caseloads that could benefit from mental health treatment. One thing I also might add to that is some people say, well, if they have a dual diagnosis and they have a mental illness, because of their developmental disorder, can they benefit from treatment? And the answer to that question is absolutely. Absolutely, yes, they can benefit. And we'll talk more about that later on. One organization that I would like to put in a plug for is NAD. And they do such a great job carrying this message. NAD's mission is to promote leadership in the expansion of knowledge, training, policy, and advocacy for mental health practices that promote a quality life for individuals with intellectual disabilities and co-occurring mental health conditions in their communities. So I would invite you to, go to their, I think I added a link here where you can go to their website. They've been around since the early 80s. They provide great training. Here's a manual, Mental Health Approaches to Intellectual Developmental Disabilities. I attended one of their trainings. The state put out back in, I think it was like 2019, there was some trainings that occurred in Salt Lake, and I know there was another one down in St. George, possibly one other location, but it was a great training, several days, and just helped the mental health system just know that there's help for our IDD population. So another help for clinicians to help decide how do they properly diagnose somebody with these co-occurring conditions is there is a DMID. This is the second edition. That's kind of a companion to the DSM that can help clinicians. So more than 100 experts from around the world have now updated the DMID to accompany the DSM-5. The DMID-2 was developed to facilitate an accurate psychiatric diagnosis in persons who have intellectual disabilities and to provide a thorough discussion of the issues involved in reaching an accurate diagnosis. One diagnosis that is especially tricky with these co-occurring illnesses is psychosis. Here at the hospital, that is something that we're tasked to do often, where we'll have somebody that has an autism diagnosis and also is experiencing some delusional thinking, maybe saying they're hearing voices, and showing some signs of psychosis. And it is not easy to figure that out, to answer that question. The state hospital is designed to do everything that we can to get proper diagnosis so that we can help answer the question, does somebody have schizophrenia or another psychotic disorder co-occurring with their IDD? With our IDD population, it's very common to have individuals have just with their talk and their language to have, talk about fantasy. The lines are blurred between reality and for them at times. But you can't just go off if somebody's saying they're seeing things and hearing things, make the jump to, well, they have a psychotic disorder. What we wouldn't want is somebody to receive that diagnosis and receive antipsychotic medications when it's not indicated, which can just complicate their life. And so proper diagnosis, especially with psychosis, is critical with this population. Here's some other common co-occurring mental health conditions. As mentioned, schizophrenia. and other psychotic disorders, bipolar disorder, other mood disorders, depressive disorders, anxiety disorders, obsessive compulsive and related disorders, trauma and stress related disorders, and dissociative disorders. I think that sometimes we can just make the assumption that, well, because of their IDD, they don't experience these same issues that somebody without an IDD diagnosis does. And that's just not true. So a therapist and medication management can really help with quality of life when treated. So other therapy roles that maybe can help the team that's trying to support somebody with an intellectual disability. Risk management. Throughout my career, when I've worked with individuals with an intellectual disability, as we know, they are very vulnerable and can be taken advantage of. Incidents of abuse are higher with our IDD population, and having a therapist part of that team. I think it's nice to have those eyes and ears that can spend time with our individuals, that can also help them navigate through life and avoid some of those situations where they might be at risk. Relationships, coaching are another important role that a therapist can play in someone's life as we, grapple with issues of settings rule and how our individuals have choices and can engage in relationships. I think it's nice to have a therapist involved that can be a voice, that can help navigate some of those very tricky relationship issues. Have a couple of examples of that. I hope I can present this okay.
Allergies of any kind?
Can you hear that okay?
Yep.
Okay.
Interesting question to ask. Why do you ask? Is my nose?
No. Oh, it's just I was wondering if there are any foods you were allergic to.
Not that I can think of. No, I really don't like the smell of peanut butter. I don't know how it happened, but every time I see a thing of peanut butter or ketchup with it, it's like, ugh.
Oh. Okay, let's. Do you like nature by any chance?
That is a very good question. I've never really thought about that. I guess I am more of a city person. I prefer the hustle and bustle.
Hey Connor,
Yes.
are you writing yes or no while they're still sitting there?
Am I not supposed to?
I'm not going to wait till they've left to finish. I want to see.
Damn, knew I'd messed that up.
So there's an example, just a simple example. By the way, I love Connor. I don't know how many others have watched that Netflix series, but he's my favorite. Where just simple coaching can help somebody navigate through life. Here's just one other example.
It doesn't matter whether you're on the spectrum or not on the spectrum. Everybody has a basic human right and a basic human need for connection and love. So, here's the girl. Why do you want to have this girlfriend?
It's because she's nice.
What will you and the girlfriend do together?
Together, we should go out on a date.
Yeah? What else do girlfriends and boyfriends do?
Hug and kisses.
Hugs and hugs and kisses.
So would you like to do hugs and kisses?
Yes.
Yes. When we go on our first date with somebody, what do we do on date number 1?
We should introduce her by name first.
What if the girl wants to sit down at the table? What would be a good thing for you to do?
Good.
What's this? So you and I'm going to come, pretend Dad's not there because we don't want Dad on the date, do we?
What?
No way, Dad's not coming on the date. You show me what a gentleman would do if Jodie's coming on to meet you. Okay, you ready?
Gentlemen.
Hi. Here you go. Here's your seats.
First of all, you have to introduce.
Hi, my name is Kellen Wong. Nice to meet you. My interests are manga and drawing and computer.
Okay, first of all, you want Jodie to sit down so we're on the same level, don't we?
Yes.
Okay, so here's my chair here. Try again.
Okay.
Okay, you ready? Here I come.
Hi, Jody. My name is Kevin Wong. Nice to meet you.
Hello, Kelvin. My name's Jodie.
Then the chair, let her sit down.
Here's your chair.
No, go out and take the chair and
Go out and take a chair.
No, Kevin, stand up, get the chair out and let the lady to sit down.
And then you say, here's
Here's your chair,
Thank
Jody.
you very much.
No, you have to.
That's a good... When the girl, she might already be sitting, but remember, before you move on to talking about yourself, we always do greetings first.
Greeting.
Now, how are we going to start talking with the girl about common interest?
Common interest.
If you just start talking about, hi, I'm really into computers and I really like games on my
No.
iPad. Okay, so the girls really like it if people, boys, the first thing they do is ask them.
A question.
Perfect. Because then the girl thinks, oh, Kelvin is really interested in me.
Okay, those are just a couple just short examples of how a therapist can help our individuals with relationships. Other therapy considerations. So what can a support coordinator do? How can they help their individual access these services? First of all, advocate for therapy when appropriate. Access to a therapist, it can be difficult. Some programs throughout the state have in-house therapy and others don't. Sometimes it's it's necessary to go through the local mental health authority for our individuals. And it's being able to articulate the needs of the individual. So when they show up for therapy, there is a clear objective on how they can help. That's what the therapist needs to know. Perhaps if you're looking in the community through a private provider find somebody that knows how to work with this population. And this therapist, they would need to be able to adapt when necessary. Repetition in therapy is an important part of how we can work with these individuals, and just understanding that just because it worked with one person doesn't mean that it works with everyone. Another important point, therapy consideration is, unfortunately, you can't force therapy. Therapy is something that requires engagement. And it's not like you're just administering a pill. Or even there's differences between a behavior support plan and therapy. A behavior support plan can actually be written, and some of those things can be implemented without engagement from the individual. But with therapy, it really requires engagement. So sometimes members of the team, they're all saying, you need therapy. And the client at the same time is saying, no, I don't. I don't need therapy. And so that is a situation that a therapist can, build rapport over time. Sometimes the sessions are not like 10 session and the issue is managed. It can take a lot more time, and a therapist that has that patience, that has that creativity to be able to reach our individuals with an IDD MI diagnosis is important. So moving on from therapy, what to do when behaviors become extreme and unsafe. When you get that call that something's happened, just ensuring that all team members are aware. Have that conversation with the behaviorist. If there's a therapist involved, with a therapist. If possible, with the prescriber. What are available recommendations? Just those team conversations when behaviors become extreme and unsafe, and being able to recognize, is this possibly a mental health issue rather than just a behavioral issue associated with the IDD. So what responses or what is out there for help if the community-based program can't manage those behaviors? So let's just kind of go through and talk about the differences between urgent care, acute care, and long-term psychiatric care. So first of all, urgent care. That would be your emergency department. That would be your mobile crisis in your area, or possibly a shelter. I think it's a challenge for our community providers to decide when that call should be made. They oftentimes, because of liability issues, they want to err on the side of caution, and that call, that 911 call, that 988 call is made just to help prevent a liability issue. But is there a true emergency? And when should 911 or 988 be engaged? I think that is a topic of conversation that should happen before the behavior occurs, so that everybody on the team is in agreement how to manage that situation. Mobile crisis. mobile crisis is something that has the state of Utah has really put an emphasis on over the past few years and build a system throughout the state. There's the mobile crisis units throughout the state they work kind of hand in hand with our EMS system. Usually the way mobile crisis works is there might be a situation where a call is made and there's a thought that, wait, this appears like it's related to mental illness rather than just a medical concern. And in some of those situations, like a team of 2 therapists, or sometimes a therapist and a prescriber that works for the mental health authority can go out and do an assessment to help decide, is this a mental health crisis? And can the mental health authority play a role in helping them get the next level of treatment that they could receive? So those mobile crisis units are throughout the state. They are accessible to everyone. You don't have to have a Social Security card. You don't have to be a resident of the state. You don't have to be on Medicaid to access that mobile crisis. It is something that is open to all. The state of Utah, if you go onto the Department of Health and Human Services website and just type in SMR, I didn't share a link. I can do that maybe later. There is a lot of great information about mobile crisis and how that works throughout the state of Utah. So just you can type in mobile crisis, state of Utah, or SMR, and it just goes through all of the services and how families can access that service. So the emergency department, mobile crisis, that's usually something that is less than 24 hours. And then there's a process where if a higher level of care is needed, then acute care comes into play. And so short-term psychiatric care, typically 3 to 10 days. Though these facilities, they do differ a bit between children and youth and adults, but our acute care hospitals are Huntsman, McKay-Dee, Aspen Grove in Utah County, down in St. George area, BMed for adults, Vive for youth. Those are examples of Wasatch Canyons, Primary Children's Wasatch Canyons. Those are examples of our short-term psychiatric units. And something to consider there is that they're tasked to stabilize quickly and to, medication is a huge part of that. But they don't have a lot of time. They don't have a lot of time to see how, side effects and how things play out over time. So it's just a short intervention, and it's important that there's good follow-up after that short-term psychiatric unit. So that's kind of the acute care. Long-term psychiatric care, state hospital where I work, we do take admissions for children and youth. Our children, usually we don't have kids under the age of, it's quite rare to have somebody under the age of 7. But we have kids from 8 to 12 on our children's unit. On our adolescent unit, kids 12 to 18. On the adult side, forensic units, like here at the state hospital, The access to our forensic units is through the court system. Average length of stay for forensic is 100 days, and they're here for mainly competency, evaluations, restorations, and through criminal charges. And more state hospital beds are moving to forensic opposed to civil beds. We still have some civil units here on the state hospital, but there's not very many throughout the state, and there's always a waiting list. It is very hard to access one of those civil beds. The way to access those beds is through the local mental health authority. And I do know clients within our DSPD system, adult clients, that their mental illness became so extreme that they required a state hospital intervention. And so it's through the local mental health authority where you can access state hospital. For children and youth, also through the local mental health authority. We don't take any direct referrals outside of the mental health authority. So the mental health authority, they're the ones that own the beds here. And when they have somebody they feel like is appropriate, then they send us a referral, and we go through that referral. And if it is somebody within the DSPD system, there has to be clear evidence that they also are suffering a mental illness, and that mental illness can be treated with medication and can improve. So that's just a brief overview of urgent, acute, and long-term psychiatric care. So involuntary commitment, what does that mean? You might have heard that statement, or somebody is involuntary committed. So somebody to access that urgent care, the inpatient care, and the long-term psychiatric care has to go through this process. Now, there are exceptions to this. There can be somebody in the community that voluntarily seeks treatment and goes to an inpatient facility and signs themselves in voluntarily. But in most cases, it is an involuntary commitment. And the commitment is not to the facility. It's not to the state of Utah. It is to the mental health authority. So wherever you're at, if it's Utah County, it's Wasatch Behavioral Health. Weber County is Weber Human Services. Just that is where the involuntary commitment criteria comes from. And there are some differences between adults and children. Adults both have to have a mental illness, but here is a difference. On adult side, he or she poses a substantial danger of physical injury to self or others, where on the children's side, a risk of harm to self or others. So the criteria for children and youth is more broad, where on the adult side, there's a substantial danger of physical injury to self or others in order for them to access these levels of care. The individual lacks the ability to engage in rational decision-making process, reading the acceptance of rejection of treatment. And on the child side, the child has experienced significant impairment in social performance. There's no appropriate, less restrictive environment. So that applies to both, that just outpatient treatment, even residential, is not enough, that they need a higher level of care. And the LMHA can provide the individual with adequate and appropriate treatment. The child will benefit from care and treatment by the local mental health authority. So even patients here at the state hospital, they are committed to the local mental health authority and placed at the state hospital. It's a bit confusing, but that's how that commitment works. Next, you might have heard how somebody about a pink sheet or a blue sheet or a white sheet. And This is not my area of expertise. I don't work with this daily, but I have some basic knowledge and can kind of share with you a little bit about the differences here. So the pink sheet, and it is pink. There is one for adults. So there's a pink, blue, and white sheet. They're all different for children and youth and adults. The examples that I've shared here are for children. So the pink sheet, this is an emergency application for commitment of a child. So to, like I mentioned, the physical custody of the local mental health authority. In this situation, this is law enforcement. So if a law enforcement is out on a call, it also can be a mental health officer. That's somebody that's been trained, that's on that mobile crisis team that can also pink sheet somebody in to emergency care. This care is usually it's for 72 hours, so it's very short term. And a link for this should be in your slides. And there's the instructions on how it works. So law enforcement, this is a law enforcement tool to help get emergency access to urgent care. Let's see if I can. The blue sheet is a bit different. The blue sheet is also for 72 hours, but this is for somebody. So there's two sides. The side one, anyone can fill out this first side and explain why they feel like the child is likely to cause serious injury to self or others, if not immediately restrained. But the second side is this is completed by a medical professional. So a doctor, an NP, a PA has to complete this other side. So somebody's in the emergency room, they need a higher level of care, then this blue sheet is filled out to hopefully access an inpatient unit. And again, this would be a short-term psychiatric unit. And then the third one is a white sheet. So if somebody is in, say, Huntsman, and they are just not stabilizing, because that blue sheet does expire after 72 hours and they need longer term treatment, then for the white sheet, this is completed by a therapist and a doctor psychiatrist. And if it's for an adult, then this would open the door for a hearing, and that hearing before a judge could order up to 6 months of commitment. And that's where somebody may come to a long-term psychiatric facility like the state hospital. With children and youth, the same thing applies, but they don't go before a judge. They would go before an examiner, and that examiner would do the commitment. And again, the commitment is not to the state of Utah, it's to the mental health authority. So just how can support coordinators facilitate collaborative care for individuals in an inpatient setting? If you have a client that's in an inpatient setting, make sure you have an ROI, that you can communicate, that you are up to speed on what's going on. Those discharge summaries and recommendations are so important. See if you can get a copy of that. Make sure that the team has a copy of the discharge summary and recommendations once somebody is discharged from that inpatient setting. The worst thing that can happen is there's recommendations made, nobody reads them, they go right back to inpatient care, and they just change medications again. So we see that all the time, that we spent so much time writing discharge summaries and recommendations, and if they're not read, and if they're not shared and followed, then oftentimes it's just a revolving door. So please, whatever you can do to take a proactive role in finding out what happened in that inpatient setting and how you can continue to support your individuals would be great. And it is 12:59, so that is the last of my slides.
That was perfect timing and a lot of really good information. Thanks, Brad. I had a general understanding of some of these concepts before today, but I feel much more on top of things, being able to see some of those differences between the pink sheet, the white sheet, and the blue sheet, and also understanding what those stays can look like for adults versus children, as well as the admission criteria. That's something that I was not familiar with. So thanks again, Brad. That was really helpful.
You're welcome.
While I'm pulling up my case scenario, does anybody have any questions for Brad? We had one question that was submitted before the session, and you did mention connecting with therapists who can work with people who have intellectual or developmental disabilities. Is there a specific resource you would recommend? Have you ever used Psychology Today? Do you think that's useful? Anything like that to connect with a therapist who might be experienced working with people with IDD, or even just be open to that and to learning?
Yeah, I think you might just have to find your niche, find your therapist out there that is willing and feels competent. I don't know that, like in the state, there's the list of no-Joe's therapists, for example, that work with individuals that I don't know that there's one for IDD-MI. But I know that there are plenty of therapists that are more than capable. And that's why I think it's even within a mental health center, if they have a list of therapists, just maybe on the front end asking who is comfortable working with our client population. And once you find somebody, then just keep referring and keep that communication open. And so I don't know that a list exists of great therapists when you don't have in-house therapists with a program.
Thanks, Brad. Any other questions for Brad before we move into our case scenario discussion? Okay, I'm going to take the silence as a no, but if you do think of anything, feel free to drop it in the chat and we'll make sure we get to it. I will go ahead and share my slides for our case discussion. All right, our case today is based on past experiences. Everything is anonymized. This does not reflect any one individual's personal experience, and there is no actual identifying information here. We will talk about Sarah today, who is our 28-year-old female with an intellectual disability. She lives with her parents and works part-time at a local community center. She has a supportive family and a close-knit group of friends who understand her needs and help her navigate daily life. Over the past few weeks, Sarah's behavior has become increasingly erratic. She's been experiencing a manic episode characterized by heightened energy levels, rapid speech, and impulsive actions. She's been sleeping very little, spending excessive amounts of money on unnecessary items, and engaging in risky behaviors such as wandering the streets at night. Sarah's parents are very concerned about her well-being. They've noticed her inability to function normally and fear for her safety due to her risky behaviors. So after consulting with her primary care physician, they decided that Sarah needed to have immediate inpatient mental health care to stabilize her condition. So Sarah has been admitted to a specialized mental health facility that cares for individuals with intellectual disabilities. Our goals with this case scenario are to determine what your role is as a support coordinator in this situation, and to identify 2 specific actions you can take to support Sarah while she is in inpatient care, and then direct Sarah to the appropriate resources for continued support once she is discharged from inpatient care. First of all, as support coordinators, how would you describe your role in a situation like Sarah's?
I think it's just monitoring her while she's there, you know, talking with the, you know, the family and just checking in on her often and getting in touch with the inpatient facility, I guess, if there's a case manager or someone there to talk to that could get information about what's being done. You know, are they adjusting meds? Are they, you know, when is she going to be released, and figuring out where is she going to be released to, and just kind of helping just monitor those details, I guess. Like that's what I usually do in those situations.
Yeah, staying informed, making sure you know where they are, how things are going. That sounds right to me. What are 2 actions specifically that you could take to support Sarah while she is in inpatient care?
Something that comes to mind for me is like coordinating, I think coordinating with maybe the therapist that might even be like more outpatient as well as someone who's inpatient, and working together to make sure you all are on the same page and whatnot.
Yeah, for sure. And in Sarah's scenario, our case scenario background didn't specify, but especially if they have an existing mental health provider and they have a diagnosis already, just collaborating with that provider so you know how things are going with them and how you might proceed afterwards. Thanks to you. What are some things that Brad recommended we could use here to help make sure we're supporting Sarah?
Maybe you should remind us, Brad.
Yeah, a couple actions. Just make sure, first of all, that you can speak with her providers in inpatient. So, you know, get a release of information in place so that you can speak with them while care is being given, and then, you know, and also be able to receive a copy of that summary of treatment and recommendations so that you know what the hospital is recommending. Those would be 2 examples.
Thanks, Brad. So making sure we get that release of information so that that communication can move freely. We have the right permissions in place. And then some of that follow-up, once Sarah is discharged from care, how would you approach directing her to the appropriate supports, making sure that she has what she needs going forward so we can prevent a crisis scenario again? T has mentioned already collaborating with an existing mental health professional if she's already connected with a therapist, so keeping that communication open. Brad, is there anything specific you'd recommend after Sarah was released from care to help make sure that we can prevent another crisis situation?
Well, one is, with a bipolar disorder, she's in there for a manic phase. Medication will be key. The therapy is secondary to that issue. So just make sure that there's follow-up with medication, that that she's taking her medications, that Sarah, that she's receiving them on time. That would be just, you're an extra level of oversight to make sure that there's compliance with medications. Also, for anybody leaving an inpatient stay for a mental health issue, if they don't have a therapist, then helping the family, the provider, whoever is to access. And then I think being able to present to the therapist the specific need. Sarah had recently been diagnosed with bipolar disorder, and we need help from a therapist with medication compliance, or to help us monitor ongoing symptoms of bipolar disorder. That's the kind of support that we need. So being specific, not just Sarah has autism, can you see her for therapy? Be specific on the mental health need.
Thanks, Brad. So more of that communication and also connecting with that prescriber here could be really helpful, making sure that they know what's going on, they can make changes if needed, and just that extra level of oversight like you mentioned. The last thing we'll touch on today, since this is an ECHO session, kind of like a community of practice, I would just love to know if any of you as support coordinators or case or care managers have experienced anything similar to this. And if you did, what you've learned from that and how today's session might help you address those going forward. And I'll share a little bit. So I am not a support coordinator currently, but I was at one point overseeing residential habilitation services for a disability service provider and encountered a number of crisis scenarios. But in reflecting on those, something that I think I would do differently after today's session is putting a little bit more effort into that collaboration with the prescriber. I can think of a scenario where we made some efforts to have that collaboration, but didn't have great follow through. So I think in future scenarios like this, I would put greater effort in that connection with the prescriber.
I've definitely over the years had a lot of clients, be in and out of inpatient facilities at one point or another. And I think, the biggest thing really is just that open communication between the team. And I've had good experiences where it's gone well, and the place they're leaving from has given great instruction or information to the either family or provider of the client, and I have had ones that haven't gone as well, where they're either not able to get a hold of them, or there's just no communication made on the end. They're just like kind of kicking them out the door, so to speak. But so it can go either way, but I think there's just definitely just those efforts of, really trying to get that information from them so that the person can have, the most successful transition back to wherever they're going home to, is key. And then just following up even after, right? I mean, like just those continued things that we do anyway through visits and communication with families and providers to, in the weeks to follow, maybe increasing that a little bit, like, even though I maybe only need to see them once a month or once every other month, maybe just increase that while that transition's occurring, just to make sure that things are still going well.
Yeah, awesome. Thank you, Julie.
One more thing came to mind, if that's okay.
Yeah, please.
I think sometimes when, and not just with the IDD population, but inpatient stays can be reinforcing for some. And I think when somebody leaves, there's times where they may try to do things just to go back for whatever reason. And good communication with a team to get ahead of that would be important, because before you blink, they could be back 4 or 5 times.
Mm-hmm.
And because I've known individuals that they like that they could just order food, like they like the menu at the hospital, that they could just oh, I want this. And so there was additional psychiatric stays because of that. Mm-hmm. Behavior had escalated to the point where, because they just wanted to order some food, something that they like there. So really talking about, especially those that have some personality disorders, those inpatient stays can be reinforcing. So talking through those as a team, how can we stop that cycle? If it's just, if it's not needed, how can we be on the same team or on the same page when somebody is escalating their behaviors just to get inpatient?
Yeah, good note. Thanks, Brad. All right, I'm going to take the extended silence as it people are ready to end a meeting after Thanksgiving break. So we will wrap up just a few minutes early today. I want to thank you guys, all of you that were able to attend today. I will send out our flyer about our December 16th session within the next day or two. And if you remember, those will be about facilitating and building skills for individuals with IDD and mental health concerns. Please share that flyer when I send it later today with anyone you think may be interested in joining. We will have another presenter from the Utah State Hospital that we are, again, really lucky to have. So I'd appreciate it if you'd share that and encourage your peers to attend. I will get that information out later. If you have any questions for me, I'll stick around for just a few more minutes before I close out this link. If you'd like a certificate of attendance or a CEU, just be sure to fill out that survey. The link's in the chat. Otherwise, we can wrap up. Thanks, Julie, for your contributions today and helping us discuss some of these questions.
Thanks. No problem.
I'm
happy to talk if no one else is talking.
Well, I appreciate it.